Hello again, students. This is the fourth respiratory lecture in the respiratory physiology section of Vander's. When we last left, we were talking about compliance, surface tension, and all of the components of compliance. Today, we want to focus on the regulation of airway resistance, the tubes that go from the trachea all the way down, as you can see in this diagram, all the way down to the alveoli. As you work your way down from the trachea, which is the largest airway tube in the body, the trachea is surrounded by cartilaginous rings. Those cartilaginous rings prevent the trachea from being very flexible. They are C-shaped rings, and so if you're looking at them from above, they look kind of like that. And so this gap between here and here is the only space where the ring can actually get a little bit smaller or a little bit bigger. So the trachea itself doesn't have much ability to change. As you work your way down the bronchial tree, from the trachea down the bronchial tree, you begin to lose cartilaginous rings and you start to add more smooth muscle. And as you add more smooth muscle and lose cartilage, you increase the tube's ability to constrict or dilate. So the airway radius is the main determinant of airway resistance. If you see here in the bottom, this equation here, the resistance equation, right? This is just Poissier's law, which we learned about in the cardiovascular section, flipped upside down. And remember, Poissier's law describes flow through a tubular system, which this is essentially a version of Poissier's law. So I'll just read this for you, and then we can move on. Airway radius is the main determinant of airway resistance. Airflow, F, is a function of the pressure differences between the alveoli and the atmosphere, divided by the airflow resistance. So when we're looking at Poissier's law, right? Flow would equal the change in pressure to the radius to the fourth power divided by 8 times the length, and being the viscosity. So this is essentially Poissier's law. It's a different form. We already know that air enters the lungs when the alveolar pressure is less than atmospheric, because remember, atmospheric is 0 no matter where you are on the planet. And in order for air to flow into the lungs, it has to flow down its pressure gradient. So the pressure in the alveoli decreases, therefore forming the gradient down which air is able to flow. In order for air to exit the lungs, the gradient has to be reversed. And so the alveolar pressure now has to become positive compared to atmospheric. You should memorize or remind yourselves of these two equations. The deeper you get into the lungs, the overall resistance in the lung decreases. Now, this is hard to understand for some students. Think about it this way. The deeper you get into the lungs, the larger the surface area becomes. If you take the surface area of the inside of all of the tubes, in the deepest parts of the lung versus the surface area of all the tubes in the more proximal areas of the lung, you see that the surface areas are vastly different. As the surface area goes up, resistance goes down. As the surface area goes down or decreases, resistance to airflow goes up. So, and this is just based on total numbers. There's only one trachea. The resistance in that area of the airway system is relatively high. Then you break that into two bronchi. The resistance has gone down because there's more surface area between these two bronchi than there is in one trachea, and so on, and so on, and so on. Upper airways, the bronchi have large radius and low resistance, one pathway for air to take. Deeper in the lung, terminal bronchioles, smaller airways increase resistance in individual airways. Large number of parallel pathways result in lower overall resistance. So this is where students somehow get confused. So let me try to clear this up. If I have a very large tube, and I have that next to a tube that is of the same length, but that has a much smaller diameter and radius. The question is, which one of these two has a lower resistance to airflow? And if you guessed this one, you would be correct, right? Same length, bigger radius, bigger diameter, lower resistance. However, if I had a series of these smaller airways, the total resistance of all of these, in this case the 5 combined, would be lower than this large one. But if you're only comparing one vessel, one tube, large versus small diameter, the larger one has a lower resistance. So when we're talking about resistance in airflow or blood flow, whatever you're talking about, liquid or gas, are you talking or comparing one tube to another tube, one being a large diameter, one versus small, or are we talking parts of the system? This part of the system being, the initial part of the system versus this part of the system having tens and tens of thousands or even millions of these airways. It makes a difference. Airway diameter is also affected by lung volume. In this graph, where resistance measured in centimeters of water per liter per second on the y-axis versus lung volume, you can see that as the lung volume increases, the resistance to airflow goes down. Why is that? We'll just read what's below and then we'll explain. Airways inside the lung are elastically tethered to walls of the lung. When the lungs expand, airways are stretched open. Increases the radius, which equals a decreased resistance during inspiration. During expiration, airways recoil inward, because they have elastic capabilities too. Decreases the radius, increasing airway resistance. So this goes back to something we've already learned when we were talking about emphysema. So these red strings are tethers. When the lung expands, right, the lung tissue, remember this is all connected to the lung tissue. Let's imagine that this particular lung only has one alveolus. So this is the lung wall, right? This should be review. It should seem vaguely familiar. Right, and this area in here is the intrapleural space, right? And the intrapleural space is filled with water, interstitial fluid. And then this area here is the chest wall. And remember that the chest wall is connected to the alveoli via the intrapleural space, which is connected to the lung, the outer portion of the lung, which is connected to the tethers, which are connected to the alveoli. When the chest expands, when the diaphragm expands, there's a pull on these tethers, right? The tethers start to get taut. They start to get taut. And they pull on the alveoli, but they also pull on the airways. They pull on the airways. And they pull the airways open more. And because of that, because the diameter and the radius increased, right? Then based on the equation, the resistance, so you're going to put this into this part of the equation, the resistance has gone down because the radius is always to the fourth power. So, and as the lungs compress when you're expiring, those tethers that are attached to the lung, that are ultimately attached via the interstitial space, the water, to the chest cavity, start to loosen up again. And so they go back to their original radius. And so that therefore the resistance increases. At low lung volumes, airway resistance increases greatly. Expiratory flow becomes effort independent. So what the hell does that mean? At roughly 40% of vital capacity. 40% vital capacity, no matter how hard you blow out, no matter how fast and how much force you try to move air out of your lungs with, even if you use every muscle available to you, the amount of airflow that can occur out of the lungs is effort independent, which means you can't do anything about it. There's no point at breathing any harder. Now, if we think about it, let's go back to what we've already learned. We know that the lungs want to collapse because they're a big old rubber band. And they want to collapse to 0% lung capacity. We also know that the chest wants to sit at 60% lung capacity, right? Total lung capacity. And we know that the balance point for the two is roughly about 40%. So this 40% becomes really important because at 40%, they're in balance. Okay? So let's go back to this expiratory flow and effort independence. If you take a breath to 100% capacity, okay, to 100% capacity, and you expire using all of your muscles, but only at 50%. Oops. Only at 50%. So this line here. You will notice that when you expire, right, you get an initial increase in flow rate up to about 4 liters per second. And then by the time you get to about 40%, there's a pretty significant drop off. So then you do the same experiment where you take the biggest breath in, inspiration you can take, and now you use about 75% of the amount of force that you can use to expire air. Again, you get an increase in flow. This time the flow gets to about, I don't know, 7 liters, 6.5 liters per minute, and starts to tail off at about 60. By the time you get to 40%, you'll notice that the decrease, the slope of the line of the red and the slope of the line of the yellow is just about the same. Remember, you're using 25% more force, and the slopes aren't that different. Finally, you take the biggest inspiration you can, and you use so you get to 100% again, and now you use every muscle. You use 100% of the force that you can muster for expiration. You get an even bigger increase in expiration flow. So you get up to about 9 liters per minute, and it starts to tail off just like the other two. By the time you get to 40% again, you'll notice that the slopes are almost the same. So that's the first thing you got to do is memorize that. That's just true. The second thing is understanding why it's true. And it's explained down here. At the arrow, at 40% vital capacity, right? At 40% vital capacity, no matter how hard you try, air flows out at the same rate. The lung volumes there's less elastic tethering once you get to this 40% vital capacity. And the airways start to become compressed. So not only are you under normal circumstances when you expire, there's a recoil effect of the lungs, and the tethering is starting to loosen up. So you don't have as much tethering holding the airways open. And so the airways start to become compressed. You increase resistance to flow because there's more friction. When the lung is less stretched, there's also less recoil. So by the time you get to 40% of vital capacity, you don't have as much recoil from the lung, and the airways, because of the tethers starting to loosen up, start to partially collapse. The resistance goes up so high at 40% airflow that no matter how hard you try, you cannot move air out any faster. So that is what we call effort independent. If you breathe out at 50% effort, 75% effort, or 100% effort, by the time you get to essentially the balance point, very close to the balance point between the lung and the chest wall, it becomes effort independent. What happens to expiratory airflow during disease states? Well, we've already talked about emphysema, and we've already talked about restrictive lung disease. So emphysema would be here. It is a type of obstructive ear disease, meaning there's an obstruction to airflow. There's something in the way, or partially in the way. And restrictive ear disease, which is like fibrosis, right? So it's fibrosis. And this is obstructive. This graph represents on the y-axis expiratory airflow in liters per minute, and on the x-axis the lung volume in liters. And you can see it roughly represents average person who has about 5 to 7 liters of lung volume. The red curve represents normal lungs during expiration. And you can see that as expiratory from about 6 to 5 liters, that first liter, if you take a full breath and you start to expire, you're going to get maximum expiratory flow because you've got the recoil, the airways are wide open. And it's a pretty good airflow, right? You can get up to 400 liters per minute. And then it starts to decrease. And then by the time we get down into this area over here or so, it becomes effort independent, just like we just talked about. Then what happens? So this is normal, right? And you sort of live in this space here. Most people live in this space here, right? They're not overly expiring, right? You're not usually blowing most of your air out. So you're living in this area between here and here most of the time. So then what happens when you have obstruction? Let's remind ourselves what emphysema is. Emphysema is a condition in a series of conditions called COPD, chronic obstructive pulmonary diseases, that include chronic bronchitis, but don't include asthma. And when you have that, remember that, let's say that this has been caused by years and years of smoking. Collagenase is being produced. It's the enzyme that breaks down collagen connective tissue, of which the tethers are made up. It starts to break down the walls of the airways, and it starts to break down the tethers. So problem number one is you have less tethering available to keep all airways even modestly open. Now you still have muscle that surrounds them, so you still have that. Remember, that muscle is getting damaged. In addition to that, so that's starting to collapse the airways. They're smaller than they should be. Then you have inflammation, much like asthma, inside, right? So you have inflammation. So let's say that is a normal. Let's do this in the same colors. That way it doesn't confuse you. So we're going to start off with the red here. Let us say that this is a normal airway in the red, and this is the normal amount of tethering. Okay, now those tethers are healthy and connected to the lung, and they're keeping that airway to that size. The smooth muscle surrounding this tube, let's say it's a bronchiole, is also healthy and partially dilated. Okay, so there's the opening, and we'll just make it look more like an airway. That's right, because there's a boundary. So this is the middle. It's where air can flow. Now we want to take a look at what that same bronchiole would look like in an emphysemic patient. Well, what would happen is and I'm intentionally leaving gaps here because these tethers are broken. They're no longer attached, right? So the connection of the emphysemic patient's tethers to the wall are less robust. What does that do? Well, it makes the internal diameter of this airway smaller. But then on top of that, what you have is you also have inflammation, which makes the internal diameter even smaller. So this is the opening to airflow. So you have obstruction. And so even if we take a look here with the total lung capacity, right, we're taking a look at the green. If we take a look at the emphysemic patient, because of fewer tethers and because the chest is winning this battle, this tug of war between the chest wall and the lung, the emphysemic patient tends to have a greater total lung volume. So you can see this at 7. And that's because of these fewer connections of the tethers. But those fewer connections are also connecting less to in this case, the bronchioles. And on top of that, you have inflammation. So the airway is constricted even more. What ends up happening is that in an emphysemic patient, expiratory airflow is half to a third, right? Half to a third compared to a normal healthy lung. And this is why. If we now take a look at a patient that has fibrosis, that person is having lots and lots of tissue buildup. You can think of it. It's restricting. They probably also have inflammation. A little bit. So these people can't expand even if the tethers are there. They're glued down. Everything is becoming stiffer, so there's more connections. They're glued down. So these people have airways, alveoli, that are more restricted. They can't expand as much. So their overall lung volume, right, is half of what is normal. So it's about 3. They can muster about the same expiratory airflow as an emphysemic, except they're starting with smaller lung volumes where the emphysemic has larger lung volumes. This is caused by obstruction. This is caused by restriction where the airways just can't open up enough. So there's different etiologies of the disease and progression of the diseases. So in general, emphysemics and people with chronic bronchitis have larger lung capacities than a normal person, but because of the obstruction, because of the breaking of the tethers, and because of inflammation, they can't muster. Their volumes stay really big because the chest starts to win out the tug of war between the lung and the chest, and they can't move much air, and so they only have this 1.5 liter volume that they can play with. The fibrotic people have a much smaller top end capacity for volume, but they're also playing with a much smaller overall lung volume. They can't take in deeper breaths. So in an emphysemic, it's very easy to take in air, but very hard to release air. In a fibrotic person, it's hard to do both, in and out. And so you have 2 different kinds of diseases, which ultimately both end up causing a reduced expiratory flow compared to the red, which is normal. This slide is specifically on lung fibrosis. The right side is constricted, thickening of the lung tissue, inflammation and fibrosis, very low compliance, resistance to air change in the lung. Lungs are constricted, lower air capacity, rightward shift. Airways also constricted, high resistance. So this is just a reiteration of what we just talked about with this. This is my all-time favorite golden age bodybuilder. His name is Frank Zane. He's still alive. He's in his 70s. He was one of the few people ever to beat Arnold Schwarzenegger in the 70s, 60s, 70s. So the reason I have this picture here is because Frank is doing This is during one of his Olympia wins. Frank is doing a classic pose that was done by classic physique bodybuilders. It's called a vacuum pose. And you can see here that he sucks in his gut and he gives you this vacuum type of pose. And the reason I have this in the respiratory section is because you had to practice doing this. And bodybuilders from the 60s and 70s weren't the only ones that did this. In breath work from different cultures, from India, Southeast Asia, Pakistan, Iraq, Iran, there have been many cultures who have done breath work, yoga. And part of that breath work involves being able to completely manipulate your diaphragm so as to be able to completely expire all of the available air in the lungs. And so what Frank has here is he's been able to completely expire all of the air from his lungs and using his transverse abdominis, which is a deep muscle of the abdomen, move all of his organs back and up and give you this pose. On the other side of this, on the flip side of this, he would also have the capacity to take in a deeper breath. So people who practice this type of posing, the vacuum pose, actually have a larger use of a larger percent of their lung capacity than a normal person because they practice using the entire extent of their lung capacity, both in and out. And that's why I have this here, because most people can't do this because they don't practice it. They don't use their lungs and their diaphragm this way. If you did, this is something that can be learned. Now, what makes this so amazing is, and what made him so amazing is this is the pose that he was known for. And he's not very large. He's about 5'10". He competed at about 195 pounds. Was that he had this teeny tiny waist. He was able to really pull his transverse abdominis back. And then he had this amazing set of latissimus dorsi and this fantastic serratus anterior. And so this is, of all the vacuum poses that have ever been done in the last 50 years, this is the top, the peak, right? This is the what the perfect vacuum pose looks like. And again, this is something that can be learned, and this type of work has actually been shown to be beneficial for people and healthy. So that's why I wanted to put it in there. It's also an interesting trace back in history. I think I'll stop here, and in the next lecture, number 5, we'll start talking about lung capacities. So I hope you have a better understanding of how the resistance to airflow in the actual airways, affects flow, both under normal resting eupneic conditions and under forced expired during normal healthy lungs, during normal healthy conditions, and under conditions of airway restriction and airway fibrosis. All right, guys and gals, have a great evening, and I will talk to you soon.